Thank you so much. It's a great honor for me to give this presentation, and I'm feeling very happy to be here. So we will focus on echo imaging. And when we have to do with a patient with significant MR, we need to start from this algorithm, this very nice slide, showing that we first assess the clinical context of the patient, the heart failure symptoms, the symptomatic status, as well as the medical history, comorbidities, previous heart failure hospitalization, hepatic and renal dysfunction, quality of life, and objective functional assessment. The next step is the transthoracic echo, which is recommended as the first-line imaging mode for MR assessment, and in some cases we need also to do exercise echo when there are questions about discrepancy between symptoms and severity of MR. And of course, the next step is transesophageal echo that is recommended for a better and more precise mitral valve characterization. And we talked a lot about MR etiology, we talked a lot about mitral valve anatomy. So we have two broad categories of MR etiology. The first one is primary organic or degenerative MR that has to do with the mitral valve leaflets. And the second type is secondary MR, the functional MR that has to do with mitral annular dilatation. And this is a case with primary MR, a patient with mitral valve prolapse, at least moderate MR, and you can see there is also a little bit of sum at the LVOT. This is another case with primary MR and posterior flail of the posterior leaflet. We see that there is a free movement of the posterior leaflet in the LA. And going to the secondary MR, we have two types, the atrial and the ventricular functional MR. A little bit of information is that we know a lot about ventricular functional MR, but the data are not so many concerning the atrial functional MR. And this is a secondary MR due to ventricular functional MR, whereas this is a secondary MR due to LA remodeling. What about quantification? We all know the quantification of mitral regurgitation using multimodality imaging, but basically we need TTE, TOE, and maybe in some special cases we can also do MRI. And we have a stepwise analysis of MR starting from the transthoracic echo, and we use quantitative and qualitative measurements that we all know, starting from the qualitative and quantitative, going to the PISA method that we all know we use in the assessment of a mitral regurgitation ahead of the procedure. What is the problem with the ERO and the PISA method? We know that based on the guidelines, both primary and secondary MR have the same cutoff points. However, error is sometimes underestimated in secondary MR, and we need to go for lower cutoff values. The error may be 0.3 and the regurgitant volume 45 instead of 40 and 60. So there are other volumetric methods that we may calculate regurgitant volume, and as well as we need to do continuous wave and pulse wave Doppler, and we can see that there are specific parameters that we need to take into consideration concerning the severity of MR. Going to the TOE, TOE can show us a lot of details concerning the mitral valve mechanisms of regurgitation, and starting with this protocol dedicated to the edge-to-edge repair procedures, we see that we start at the mid-esophageal view. In the higher views, we can see A1 and P1, at the same time as aortic valve. Going a little bit lower, we can see A2, P2, and further on A3, P3 scallops of the mitral valve. And in this way, we can see where the jet starts. Then we need to see the atrial septum at the short axis and the bicaval view. And then we go further on to this classical intercommissural view where when we put the cursor next to the left atrial appendage, we see the A1, P1 at the LVOT in this view. Going further with the cursor at the middle, we can see A2, P2, and further on, we can see A3, P3 scallops at the LVOT outflow tract. And of course, we need to do, this is a very crucial image, at the surgeon view. We can see that the aortic valve is placed at the 12 o'clock and the appendage at the 9 o'clock, and we can see anterior and posterior leaflets, and with the color we can see precisely where the jet comes from, but also multiplanar 3D echo, we can see the MVA and maybe do a planimetry and see what is the MVA of the patient that is going to go for the procedure. Also, 3D PISA method with the TOE is also available and may have a good quality in some patients and may be a useful tool. So we talked earlier about the candidates concerning the procedure. We know that we like the COAPT-like characteristics because these patients actually have a larger ear and a less dilated left ventricle. So it is the patient that has a disproportionate MR. That means that the severity of MR drives the clinical course of patients. And after this discrepancy between the COAPT and MITRA-FR, we also may take into consideration the regurgitant fraction that when it is over 50%, it goes for a high-risk patient. Instead, when it is lower than 50%, then we talk about a low-risk patient. So besides the quantification and the severity of MR, we need to see the patient overall. We need to stage the patient. As we said earlier, it's not like we look only the valve, but we look also on the hemodynamic consequences of severity of mitral regurgitation. So I think this is the most crucial slide. We see that we should know whether there is severe LA involvement, where is severe pressure and volume overload also at the right ventricular cavities, where we have systolic pulmonary hypertension, and whether there is biventricular failure. So this is very critical for the prognosis of the patient. What about the device selection? We talked about the devices. We need to have a plan ahead of the procedure. And of course, we have two major companies, the Abbott and the Edwards company, with different devices. And based on the anatomical criteria, we need to check which is the best device for each case. And of course, it's not only the ideal patient, but it's also the experience of the center that, as we saw earlier, we may have a patient that is in green, so it is an optimal patient that is easy, but we also have complex patients that need to have a higher expertise in the procedure. These are the criteria that we need to take into consideration when we select the device. And after the MDT, we may go on for the interprocedural guidance that the TOE is critical. And this is a case of a 56-year-old patient with ischemic cardiomyopathy. This is the coronary angio, showing that at the last angiogram she had an RCA PCI. So the patient further on went for an ICD. This is the ECG of the patient, and there is a short QRS duration, and this is the X-ray of the patient that shows a huge heart. So from the transthoracic echo, we see biventricular failure, significant functional MR, and as you may see, there is a dilation of both atria. And going further on, we can also see that there is significant pulmonary hypertension with actually significant tricuspid regurgitation. So in this patient, we proceeded with a TOE. We can see from the four-chamber view that there is a functional significant MR, and also from the surgeon's view that it's actually from the A2P2, but goes along the mitral leaflets. So this is the TOE for the septum at the short and long axis, and going further on, this is the procedure. These are the steps of the procedure: the vascular access, the transeptal puncture, then the steering and positioning of the guide and delivery system, leaflet grasping and deployment. And as you can see here, we need to follow the interventionalist concerning the transeptal puncture, depending on the type of MR. If we have a primary MR, we may go further lower in the septum. If we have a secondary MR, we may go upper in the septum. So we need to puncture at the fossa ovalis, and a high puncture allows for more working place in the left atrium. So going on for the guidance of the steerable catheter, we need to check for the trajectory of the clip, and then further on for the perpendicularity of the clip. As you may see here, this patient had actually very good results with minor mitral regurgitation. What we need to check at the time of intervention after the deployment of the device, we need to check all these parameters for the device related, that we may have a secure attachment, that the device is placed securely, we don't have a potential of device embolization, there is no leaflet injury, and there is a residual MR that is less than 2. And of course, the transmitral gradient that may not be so accurate at this point, but it should be less than 4 or 3 millimeters. And of course, we need to check other parameters with focus on how huge is our MR, is it a good result, do we need to redeploy the device or not. So these are all the parameters that we need to check, and actually the appearance of spontaneous contrast in the LA after the disappearance of spontaneous contrast shows a very good result. So in this patient, we also checked afterwards the septum, and we also closed this septal defect due to the high pulmonary pressures of the patient and the RV failure. This is a very quick case. So in this case, we put 2 devices, and going to the conclusion, transcatheter mitral valve repair is considered one of the most challenging interventional procedures. We need to have experience. Experience is growing every day with new cases. To achieve optimal outcomes, we need to have a good patient selection concerning the clinical and anatomical criteria. And furthermore, we need to consider also other transcatheter treatment options or other maybe surgical options in patients that are not considered good candidates. Thank you.
Congratulations, excellent talk. So I have 2 questions for you. The first is, what's your approach when we deal with moderate mitral regurgitation, which is discordant with the symptoms? So, for instance, there is a patient who had a history of pulmonary edema, but comes in the echocardiographic lab with moderate MR. How do you approach? Do you load the patient? Do you give fluids? Do you do bike? And second, you mentioned briefly about the CMR in mitral regurgitation. So which are the cases in which you order a CMR?
Thank you so much. Actually, for the moderate MR, we need to first start from the clinical context of the patient, the heart failure symptoms, the functional classification, whether there is a high brain natriuretic peptides or not. So first is the clinical context. Then is the staging of the patient, where we have hemodynamic consequences of the MR, when there is concomitant coronary artery disease or not, when the LA is dilated, if the LV is dilated, so if there is pulmonary hypertension. If it's only the moderate MR and there are symptoms that cannot attribute it to this MR, maybe we can do an exercise echo, so we can exercise the patient and see whether the MR gets severe or whether the pulmonary systolic pressure increases. So I think overall, these are the first things that we need to do. The other thing is that when the LV is not good and there is moderate MR, it's a big issue how early we should go for the patient to be treated, because already the LV for some reason is dilated. And in some cases, we don't know whether the LV is dilated due to a DCM maybe, or due to MR that is progressing and is underestimated at that point. Concerning the MRI, I am very happy to do MRI in young patients that are going in surgery, and especially congenital patients or patients with prolapse that are in the gray zone of the severity of the MR, because in some cases with prolapse we may have a mid to end systolic regurgitant volume that is not so severe. So I think MRI is good for the patients that we need to find the timing for the intervention, and patients that we need to find the volumes of the LV and whether we need to go at that time or maybe wait a little bit longer. So maybe in young patients and congenital patients or patients that we have questions concerning the severity and the volumes of the ventricles.
Exactly. I think this is very important to identify the damage as soon as you can, because when you're dealing with a disease like that, maybe it's not like TAVI, of course, but we know that when we have a non-reversible damage in the heart, then you get to have a more severe prognosis. Dr. Belakis, do you agree?
I have a question that there is a group of patients that at least the surgical community gets more involved. Excellent talk, by the way. And these are the patients with annular disjunction. So I was just kind of wondering whether you get any patients in your practice and whether you change anything in the preoperative workup or whether you change anything in terms of treating these patients.
Annular disjunction with prolapse and significant regurgitation, or it's just arrhythmia?
Significant regurgitation.
Yes, I think this is a very interesting issue because there is no data concerning the arrhythmia status of the patient after surgery. So, of course, we need to follow the patient for the ventricle and the timing of intervention, but I'm not sure about the arrhythmia status of the patient and whether, after correcting the valve, whether the arrhythmia still exists, the risk of arrhythmias. So I think this patient needs to follow up long-term with Holter monitoring and actually track any arrhythmias that are maybe life-threatening. I'm not sure if you have any data concerning the arrhythmia in long-term patients that had surgery for...
What I usually do, I send all these patients for CMR because I want to see whether there's any fibrosis.
Of course, for the CMR, yes, of course, because we need to see the fibrosis and the area there. But I think the question is whether when you correct this patient with another valve or a repair, what happens about this arrhythmia that is there at the disjunction point?
Congratulations, Dr. Drakopoulou. It was an amazing talk, very complete, and thank you so much for that. In regards to the MAD, there is actually, they tried in the past to operate on patients with MAD and MR, and actually the MR maybe at some points was like moderate MR, not only severe MR, in order to identify if those patients are going to have less arrhythmias in the future, and they actually failed to show that. So operating on a patient with MR, moderate, let's say MR and MAD, for the arrhythmias, it's wrong, and we don't actually do it. Actually, what is happening now, we know about MAD, but what happened in the past when surgeons didn't know about the existence of the MAD, when they were actually repairing the valve, and please tell me, Dr. Roubellakis, if I'm wrong, that while you are placing your suture, you are actually maybe fixing the MAD, so it's something that surgeons can fix the MAD, especially if I guess they try to. However, with the mitral clip, it's something that it's going to stay on the patient, with the patient. Another important point I think that we always need to have in our mind is about the clefts of the mitral valve. If there is a cleft and someone tries to place a clip there, maybe the cleft is going to open, and the result it's not going to be what you are expecting to see. I don't know if Dr. Sparias, in your experience so far, a cleft that can be easily identified with 3D from the ventricular side, not from the atrial side, anytime confused you or was difficult situation for you?
Clefts are very strange things. Sometimes you think there is a cleft, but in reality it's just a dropout effect on the echo, and it doesn't have any significance. I mean, we take special caution when we see color coming from within the cleft. Then we know that this is a real cleft. And sometimes we have to position our devices in very unusual clocking when we have clefts. Sometimes we go against the usual law of following the smile of the mitral valve. We try to think, what if I position my device in this clocking, if it's going to open the cleft? So sometimes we go very unconventional and we go the other way to fix the MR, but at the same time to constrict the cleft or to reduce the possibility to enlarge it, or even to try to close the cleft at the same time.
Good, so thank you.